Hey, everybody, welcome back to Therapists Uncensored. Ann Kelley and I are both here today, and we have two guests for you that we're really excited to bring you. We have tons to learn. This is I don't know if it's a new therapy, but it is going to be new to us, and I think new to many of you. So welcome, Margaret Martin and Deb Pollack.
Hello.
Would you guys start by just describing yourself a little bit so that we can orient the audience to who you are?
Sure. I'm Margaret Martin. I'm a licensed clinical social worker in Austin, Texas, and I practice PACT couples therapy, psychobiological approach to couple therapy, which is a model developed by Stan Tatkin, and ISTDP, which is intensive short-term dynamic psychotherapy. And that is a model developed by Habib Davanloo.
And I'm Deb Pollack, and I'm a clinical psychologist in upstate New York. So I live in Syracuse and practice in Syracuse, but I'm also a full-time psychology professor at Utica University. And I also practice ISTDP and started learning about the EDTs, which we're going to talk about today, probably about 15 years ago.
So we're going to hear, I'm so glad to have you guys both on the show. And, you know, we were talking right before we hit the start button that the work that you guys do is full of acronyms, and it's probably going to be a challenge to bring us up to speed. I can say that Margaret, you and I have actually consulted on a client, and I have really loved, learning from you and this framework that y'all are going to talk about today. So I'm excited to hear more. But when you say EDT and ISTDP, tell us more about the difference in those, the similarities. What are you speaking about?
That is a really good question. The world of Experiential Dynamic Therapies, which is EDT, is full of lots of alphabet soup and can be hard to navigate. And so definitely want to demystify that. So intensive short-term dynamic psychotherapy is ISTDP, and it was developed by Habib Davanloo as a shorter way. A lot of people get confused because they're like, oh, it's a short-term therapy. And it's like, well, yes and no. It was developed as a shorter path than psychoanalysis. So he was originally trained in psychoanalysis. And he has trained many, many therapists over the years and actually just died in the last year, sadly. And many of his students created their own flavor version, took the nuggets that they learned and put their own spin on it, or added their own voice, their own experience. And some of them very closely resemble the original model, and some of them are quite different from the original model. And they all also have their own letters to go with their name. And so we refer to the family of these models as experiential dynamic therapies. And the organization that Deb and I are both very actively involved in and on the board of is the International Experiential Dynamic Therapy Association, or IEDTA.
So let's start with the core nugget, the experiential dynamic therapies. And you said that everybody kind of has the core nugget and they may kind of branch off of that. Can you unpack that a little bit for us?
You want to do that, Deb?
Or Deb?
Comfortable unpacking the nugget, or?
Yeah. So, well, one thing I just want to add to what Margaret said, really great description of the umbrella of EDTs. If you are curious about which of those types of therapies fall under that umbrella, we have a nice explanation of it on our website for the IEDTA. And so the website is iedta.net. And I think it's one of the menu items, like about, you can click down and it'll say about EDTs. And it explains some of the, or it gives brief descriptions of some of the more common ones.
So we'll probably, just a note to Jack, we will probably have you say that again at the end.
Oh, okay.
So that when people are looking for resources, they can jump in.
Okay.
So let's jump back. Let's talk about the nuggets so that everybody then goes, oh, I want to go learn more. And then we want you to reference your website because I think that's a great next step. So tell us about the nuggets of experiential dynamic therapies, Deb. What can you enlighten us about?
The primary nuggets are really very quickly identifying the patient's defenses, specifically the ones that are causing them to have symptoms and problems that brought them into therapy. And of course, most, all psychodynamic or psychoanalytic therapies do that. But in this model, we do that almost from minute one. Right away, identifying and helping the patient themselves see their defense. Because, as psychodynamic therapists, we talk about sometimes defenses are egosyntonic and sometimes they're egodystonic. So we have to help people see them, help them see how their overuse or their rigid overuse of those defenses are causing their problems. See if we can help them get on board with the idea that they might want to let some of those defenses go or be more flexible in their use of them since they are causing their problems. And then when they're on board with that and they want to let some of those defenses go, then of course anxiety is going to rise up because if you don't have your defenses in play, you're going to get anxious usually about whatever those defenses are designed to protect you from. And so then there's an element of helping the patient notice and regulate their anxiety in different ways, depending on their level of anxiety tolerance and the symptoms that their anxiety tends to cause them. So that depends. And then ultimately to really, once you're able to help people relinquish some of those defenses, regulate their anxiety better, they can access core feelings and especially those that are conflicted and unconscious that they haven't really been able to access, but that are sort of driving the bus, so to speak, anyway, driving their use of defenses, making them anxious, and they sort of don't know why. And you can get access to that quicker and unpack all of that unconscious material quicker. So Davenlu really, his aim, because he was trained psychoanalytically, was to get to that unconscious material and help people work through it much, much faster than what you would typically do in psychoanalysis.
So can I so a couple of things. So you had sort of referenced some of the ones that fall under this. Is it like Diana Fosh's work? And just to give, because people will be familiar with some of those other ones. Like, can you just give some that might be more commonly known that are examples of these EDTs?
Yeah, so Diana Fosha developed AEDP, Accelerated Experiential Dynamic Psychotherapy, and she was a student of Davenlu. So she is one of those second generation folks that, as Margaret said, went off and kind of developed her own brand. So AEDP,
hers is probably the best known, I would say.
Right.
Yeah.
At least in the US.
I'm getting ready to sit down with her. I'm excited about that.
Yeah,
cool.
that's great.
Yeah.
And then
she was guest speaker at our conference in Venice.
Oh, wonderful.
The keynote.
Yeah.
Yep. The other ones that, at least in like the United States or North America, would be more common would be ISTDP, which Margaret talked about, and APT, which stands for Affect Phobia Therapy, which was developed by Lee McCullough, who was a psychologist, also trained with Davenlu. She had passed away a number of years ago, but her student, Kristen Osborne, has kind of taken on the helm of APT trainings. And the interesting thing about APT is because Lee McCullough was originally trained as a behaviorist, she, like in her books, especially the affect phobia workbook, she talks about the work sometimes in behavioral terms, which makes it easier for folks who were originally trained in CBT to understand. Yeah. So when they talk about an affect phobia and that you're sort of exposing people to feared affects, sometimes that's easier for folks from a more behavioral background to understand.
And that workbook is actually a really great resource as well. And a number of the people who are really active in our community are co-authors of that book.
And so for listeners that might not know what CBT is, that's cognitive behavioral therapy.
Correct.
And so go ahead.
And that workbook is called what?
Affect phobia therapy work. Is it the affect phobia workbook or affect? Yeah, I've got it in the other.
The workbook is called Treating Affect Phobia, a Manual for Short-Term Dynamic Psychotherapy.
Okay, great. We can list that.
Yeah,
list that. And earlier you had mentioned just from the get-go about defenses being egosyntonic and egodystonic. So again, just making it super easy for folks to understand. Can you say a little bit more about when something is syntonic versus dystonic, just to make it in light language?
One of the phrases we use a lot is, and I think, probably other therapy models use this as well, but we talk about, do you know what you're up to? What have I been up to?
I love that.
And so when we don't know what we've been up to, that is egosyntonic. When we are, so for example, if I have a defense structure that I frequently put people off, and then I'm wondering, God, why, I go to my therapist and why don't I have friends, or none of my relationships last, and what is the deal here? What's going on? And I really want to get to the bottom of it. And so we start exploring what comes up in these relationships. And one of the things that we find is that maybe I devalue other people in my relationships, or maybe I only let them get so close, and then I tune out or turn off. But I don't know I'm doing it. I don't realize it. So that's egosyntonic. I don't know what I'm up to. And I may even think that the problem is everybody else, right? And so one of the things that we really work on is identifying that and then helping clients to turn against the defense to have it become dystonic. Oh, wow, now I know what I'm up to. I don't want to do that anymore. But it's, one of the things that happens when we realize what we've been up to is there's a great deal of grief involved in that. Grief
it makes me think of the whole idea of AA ruining your drinking. So,
yeah.
Right.
Something that really fits with who we think we are. It's just who we are. I'm just somebody who doesn't like emotions. That's just who I am.
Oh my gosh. Yeah.
Right.
Yeah. Absolutely.
And not everybody likes them. Why do we need to like them? So it just basically fits with who I think I am. And so then it's a lot harder to recognize that it is my defense that's probably blocking and creating a lot of the symptoms. Does that sound accurate, what you're saying?
Absolutely.
Okay.
Yeah.
That's great.
And I think, okay, that was way too long a pause. Okay. Adding to that is sometimes it's not just this is just how I am, I joke a lot. People, I've always joked a lot. I'm the funny one. People like that. Or, everybody in my family's stoic. It's just how we are. We're just stoic people. So often it's not even just, this is who I am. This is how I identify with my family. This is how I identify with, the environment I grew up with. And it goes to, you don't know what you don't know.
Right. And there's not any way really to get under that, to begin to do intervention when we're identifying with the defense, which is why you're talking about turning it into something, turning against the defense, beginning to perceive it as a problem. And then we're still going to do the thing. We're going to have the problem of the defense, but kind of getting in between it where that we perceive the defense itself as a problem. Now we have a little bit of space in there to get in and begin to work. So that concept of moving it from systonic to dystonic is actually really important. And that once we can get it being a difference, now we can really begin to make movement.
It's really key. And one of the things about it, I just had a brain fart. Gonna have to, is that CPT, Deb? We'll explain what that is later. I can edit this out.
What is CPT? What is
CPD?
CPD is cognitive, perceptual,
high anxiety.
When you blank out, like I don't know what I had a thought. And it's gone.
I have that all the time.
For me, it's just perimenopause most of the time.
I know. We talk about that a lot as well. There was something that you were saying about that I was thinking, like one of the things the way I phrase it sometimes with clients is like, well, I got some good news and some bad news. The good news is, the bad news is the phone calls coming from inside the house. Like the problem is inside. This is actually related to what you have been doing and perpetuating your own suffering. That's the bad news.
I can't blame Ann anymore.
Right.
What?
Well, but the good news is, the bad news about blaming Ann is you can't do anything about it either. So the good news is
we can fix her.
Right. Yeah. Oh, I know. Yeah. Well, hey, I also do couple therapy, right? So of course. But the good news is that if the call's coming from inside the house, if it's something that I'm doing, I actually can change it. If it's something that everybody else is doing to me, as I try and navigate the world, then I can't do anything about that, and so that's one of to me is very empowering for clients as they, as what was syntonic, the thing I've always done. And I start realizing, the thing I've always done has actually been hurting me. And I don't like that. I don't want to do that anymore. That's really empowering. And again, very painful, but really empowering.
What would you do if someone resisted that?
Yeah, well, even so, I imagine it's kind of pretty common for people to resist that's not quite as easy of a step, right? They're like, hey, let me point this out. Sue, really, it's inside your building. It's not Ann's fault. There's going to be some resistance to that. Right?
Yeah.
Well, in fact, when Davenlu first developed ISTDP, like the original kind of model, and he developed his techniques for, helping identify these defenses and encouraging people to let go of these defenses. It actually was for what he called highly resistant patients, which we all, any therapist, regardless of what type of therapy they do, knows what a highly resistant patient looks like. And so it was originally intended for that. And so we have a lot of techniques for dealing with resistance. But what's actually really important and what takes a long time to learn is identifying, is this person actually being highly resistant and like very, very rigidly holding on to their defenses? And if so, we actually have some pretty, it can be pretty intensive challenges to those defenses, which I can talk about kind of what those look like. But sometimes they're not actually being highly resistant. It's that when you start pointing out some of these defenses, it brings up such high anxiety that then their anxiety actually goes over like their threshold or their capacity to tolerate it. And they start having like pretty strong anxiety reactions. For example, they might go into cognitive perceptual disruption and dissociate or lose their train of thought or get dizzy. And so we only really save the so-called big guns of our interventions for when we are really sure that the person has enough capacity to tolerate the anxiety that that's going to engender. And be able to go through that. If they don't have enough anxiety to tolerance to be able to tolerate that, we're not going to pull out the big guns. We're actually going to help them build their anxiety tolerance first, and then we can work on that resistance after that.
That makes a lot of sense, because you could be tapping into a lot of fragility.
Exactly.
Like sometimes our defenses look very strong and confident.
Exactly.
And just under that surface is a lot of fragility that I start losing my ability to be in charge, for instance. That's, my defense is like, of course people need to know what to do. And I tend to always know what it is. And all of a sudden I get questioned on that. That can be really scary. I could really highlight that actually I'm really afraid that people are going to find out I don't know what to do, or just for example.
Absolutely. It's really a capacity building model. I mean, we are constantly testing, checking for where is the threshold, and building capacity, and also bringing the client's attention to when, as the capacity increases, to helping the client recognize, like, wow, we're able to talk about this thing today in a way that you weren't able to a week ago, 2 weeks ago, a month ago. And it, there are several things. Actually, one of the things that Davin Liu did that just is kind of mind blowing to me, like how he developed this, is he would initially listen to recordings and then watch recordings of sessions every night for, like 20 years, more than 20 years. But initially that was the development of it, and watch what happened. Okay, I did this intervention. What comes after? Did it work or didn't it work? What's the result? Did it get us closer to the goal or not?
So what are some examples then of both the challenging when that's determined, but also before that about building capacity, like examples of building capacity first, and then what the challenge looks like once you determine that they are ready for that?
Do you want to describe any of those, or go for it?
Why don't you do the building capacity and I'll do the...
Okay. So building capacity, one of the things that I personally believe should be taught in every graduate school ever, and it's a little mind-blowing to me that it's not, is one of Davin Liu's enormous discoveries, which is the way unconscious anxiety is discharged in the body. And there are 3 pathways. And so to understand what we're doing with capacity building, you have to understand what the pathways are. And the first pathway is striated muscle. So that's the muscles that are voluntary muscles. So if I can intentionally tense it or move it, then that's a striated muscle. And so if a client is in striated muscle, we're seeing some, some tension in the body, or we're seeing size, then that's an indication that there is some inner conflict and that they're within the window of tolerance, to use Dan Siegel's framework, that they're, so I think of it as green light means go. Whatever, if they're in striated muscle, then whatever we're doing, any kind of pressure to feeling or, identifying defense, that's a go. The next is,
when you say this is a go, you mean that if you're working with me on my determination that I know best for most people and people are just stubborn and won't listen to me.
And I agree with you on that. So I might not want to challenge that, but
okay.
I'm totally kidding. I might, that might be Syntonic for both of us. But
yes.
Yeah. But okay, if we've decided that we're going to work on that.
If we decide it's so Syntonic, and now you've kind of you're challenging my defenses, and I imagine that there's all sorts of ways to help me be open to that, to be open to that challenge. And let's say I've got some. If you start seeing me do this strained muscle movement, the deep breathing, or I'm tensing up, then I think what I hear you saying is that you're going to take that as a sign that I am in that defense and I'm becoming more aware, and I'm open to continuing to go deeper. Okay.
Yeah. And we might say, what do you notice happening in your body right now as we're talking about this? What are the feelings that are coming up?
Right.
Right.
I'm getting a little tense. I don't really like what you're saying.
Yeah. Oh, okay. Yeah. So you're getting tense. Yeah. What are the feelings that are coming up here with me?
I'm getting all pissed at you because you're telling me I don't always know everything, and you don't know the people in my household. They just, they need me to tell them what to do.
Right. And so how do you experience that pissed here with me? What do you notice in your body? What tells you you're pissed?
I'm getting tense, and my body's, I'm getting a little mad. I feel like you don't get me. Like, I feel like you're trying to tell me something, like.
Yeah.
So so what you're doing, and I can feel it, is like you're directing me into my body and away from the conflict between the two, or for me engaging in that defensive place with you. You're like, how are you feeling in your body? And now I'm going inside the house. You're directing me inside the house, even though I didn't think I needed to go there.
Yeah. And I don't know, Deb, what, so actually one of the things is there was movement, but I didn't see any size.
Yeah. And she might have had a little projection there.
Absolutely.
She was
so
imagining you had, had some agenda or something that you were pursuing.
Yeah.
So we might need to
undo that projection. Yeah.
Okay. Take that to
like
a little bit first.
So when you say it's like you're trying to tell me something, I might say, is there something you're telling yourself? Or I don't, this is why Deb's here, because she teaches this. And so how to undo that projection.
So Deb, you're trying to, I think you don't get me. You're trying to, what did I say? You're trying to,
so notice how you're having some thoughts about what I'm thinking or feeling. Right. Yeah. And did I say
I don't like what you're thinking. You're telling me I don't think I like what you're thinking.
Well, do you know what I'm thinking though? Like, do you actually know what I'm thinking? Or are you having some thoughts about what I'm thinking? Right.
Okay. That's helpful, right? That's a great example, because now you've gone from what I'm projecting inside you. So these are these techniques of continuing to kind of get me back into my body, but in a way that you're not challenging my thoughts. You're just like helping me kind of, okay, but what am I thinking?
I want you to differentiate, right, the projection from like, oh, I'm having a thought about what Deb's thinking. I don't really know what she's thinking. As long as you're not psychotic, you should be able to do that. And then once you recognize that, once the patient says something like, well, no, of course, I don't really know what you're thinking. It's just my thought about what you're thinking. Right, exactly. So you're having the thought about what I'm thinking. And is this something that happens a lot, where you mind read others and then you get upset with what you think they're thinking? And so should we try to help you with that, since it's happening here between you and me right now? Right. And so we do some work on that first. And then underneath that, you probably still are mad at Margaret or me, whoever the therapist is.
Right.
And it's hard to be mad at you guys, but go ahead. I'm going to go with it.
Once you know that, like, okay, that's my thought that I'm having, right? We've kind of differentiated you from the projection. Then we can start to go into the anger towards me. Right.
And going back to the striated muscles that you were saying, is you could, if I'm activated and you can see me breathing, you know, and you can see me getting tense, you know that you're tapping on something there that is part of in my body that's defensive. I'm not relaxed and going, you know, I'm like going
but you're seeing it as a capability, not
Absolutely. Yeah.
It shows that I'm capable of taking that in. Oh, that's a good clarification. So I think I'd missed that. Yeah. Okay.
It's a hot spot, and we can just keep going on that track as long as they're striated.
Yeah.
Okay. So what's the next level? You have brought 3 in.
So then if what happens is somebody moves from that to suddenly collapsing into tears, or the projection becomes stronger, then you know, those are defenses that we need to deal with. Or if suddenly somebody's like, oh my God, you know, I suddenly feel like I'm going to throw up, or the skin or their eyes start blinking rapidly, or, you know, coughing, that kind of thing. Tearing up would be more an indication of feeling coming up, but then nausea, well, no,
Could be a repressive weepy.
Could be a repressive weepy, right? Yeah.
So we're going to look with the tearing. We're going to see, is it accompanied with striated muscle tension? And with crying, you know, we want to see a wave, sort of like, you know, a moment of grief comes up, you cry, you feel better, versus, I don't know if you've ever had some of those patients that just weep from like minute 1 to minute 50 and it doesn't stop. That's more of a defensive, it's a repressive defense. And so we have to deal with that. And it's not bringing them any relief. And usually those are folks that are pretty depressed and
and oftentimes when you're with that particular kind of client and there's the weepiness, it also, it doesn't tug on anything in the therapist.
Can you say that again? And whoever's moving something, try not to move it, because what you said is really important. And I think there was a paper moving on your mic. So go ahead and say that if you could.
That might have been me.
That
when we're in the room, when a therapist is in the room with someone who's really weepy, versus crying because they're grieving or they're sad, but this repressive weepiness, when that happens, it also something, the therapist experiences something. So if I'm in a room with someone who's grieving, I feel that. I feel that in my own body. I feel connection with them. I feel empathy. I feel it. When I'm in the room with someone who is weeping, just weepy, and it's the repressive tears, I don't feel that tug on my heartstrings. I don't feel a desire to comfort and hold. And it may, in fact, I may experience it as a real turnoff, as they're pushing me away. somehow, or there's sort of a victim stance that can come with that. And so there are a lot of markers that we look for, like, is it coming in a wave? Is there relief at the end? Do you see the arc of it? Or is it just ongoing? And what do I feel like inside of me as I'm attuned to this client? What do I notice? And I don't know, I think it also depends on who you train with as to how much this comes up as part of the model or models versus, and I don't know, Deb, you may know more about that as far as like.
Yeah, I don't know.
Well, that's okay, because we can, there's a lot about the kind of nuances. I mean, it sounds like this overarching model has so much depth to it that it would be hard for us to be able, so we're just being able to give everybody kind of a different sense. But what I'm hearing is that you're talking about a repressive defense. So I think what I hear you saying is things that I'm not really in my conscious awareness of, but my body holds. Is that what you're saying?
Well, also that I think the distinction, if I'm following right, is that if you're moved, that and you're perceiving it as kind of a shared affect, or that's a direction that you're going in, that's kind of the core affect, versus if you're perceiving whatever's happening as a defense, that you're gonna do something different with it. Right. And Margaret, we were still talking about building capacity.
Yeah. Oh, right. Yeah. Yeah. So the, like, if someone's, so Ann's enstrided, and Deb has, identified the projection and is undoing some of that. And if suddenly Ann starts like blinking rapidly, or coughing, or skin itching, or I need to go to the bathroom, or anything like that, that's going to be an indication that she's moved into smooth muscle, which is the next level of the 3 pathways of unconscious anxiety discharge, and that she's at threshold. And we want to help regulate that and bring her back into strided muscle. Or she might skip smooth muscle entirely and go right into cognitive perceptual disruption, CPD, which would be suddenly anything from, wait, sorry, what did you ask me? What was I saying?
Oh, you're on the right track, I think.
Or that.
Oh,
yeah, no,
sorry.
Sorry, that was
an example.
Oh, an example. But it's hard to know sometimes because it could also just be menopause.
We're all ready to help you. And
right, yeah.
Like, I got it.
Or I'm slowing down a little bit as I'm speaking. That kind of thing, which again, or it could just be menopause. Or if you're, I don't know, if your client's pregnant.
Yeah. But you're
right.
describing a dissociative or a dorsal vagal kind of body shut down, but it means that we're getting into, again, kind of an overwhelm, a sense that's over my capacity to be able to engage in this. And if we hit that, then what would be?
Well, I like that. I like the term threshold. That like you're hitting an edge, and that the goal would be to bring you back into more of a comfort zone where you're able to.
Somebody is tapping paper for whatever you can do to not tap. It's weirdly
There's
loud.
no tapping, I don't think.
Okay,
not me.
Weird. Okay, never mind. Maybe it's just my ears. Okay, so sorry.
I can hear it, but I don't.
You can hear it too.
Okay.
Okay.
And let Jack do it. It'll be on one.
Which
I can't hear it.
You're talking. Okay, nope. I won't say that again. Okay.
Oh, I took a sip.
I think that's what it was. I think she was swallowing.
Okay, so the threshold, that was great. We'll pick up from what you just said. I thought that was good. I'm sorry. I won't say another word.
That's okay.
So I'll just repeat that. And then have we finished with the capacity piece?
I think you were going to ask her, like, what would be an intervention?
Yeah, what do you do when someone's at...
Okay, so let me just pick that up. So the part that I was keying in on was this idea of threshold. And so I think that the idea is that if you notice that they're coming, to the edge or to the end of their capacity or their threshold, that then what happens?
Oh, then you help regulate. So you identify it. So I might say, oh, so I just noticed your speech slowed down a little bit there. Did you notice that? Or it looked like you lost your train of thought for a second. Did that happen? Oh yeah, it did. I kind of felt like I spaced out for a minute. Oh, okay. And so right when that happened, we were talking about, so you go back and this is where we were. Did you notice that happened right when you were talking about, I don't know, that it really is all Sue's fault and not whatever it is.
So you bring them back into more of a comfort place. So now they're resourced again. They can speak more fluidly. So that's the idea of building capacity.
And we wait until we see a sigh again. So we stay with that kind of, I don't know, is that the recap?
Yeah.
We stay with that recap until you see a sigh.
Or some other indication.
Or some other, like
muscle
that or
tension. But usually a sigh is our good indicator.
Sigh is a good indicator that
they're in striated, which is that green light, like they're within their window of tolerance. And you can go back to usually asking about feelings is typically what we're talking about because it is an experiential model. Or, just whatever, or, whatever it is, the track we were on that before they went over capacity.
So then that takes us to, so now you're ready to push a little bit. And what does that look like? We're going to pick up what is the, not attacking the defense, but what was the language?
Confronting or challenging the defense. Yeah. And so basically, as long as they are in striated and so they're not over their capacity, then especially if they're really holding tight to those defenses and you've helped them see that those defenses are there so they can see it. You've helped them see that the defenses are causing them problems in their life, whether it's symptoms or problems with other people. And then you're inviting them, to let that go with you, like work on doing something different. And if they're still holding on to it and they don't want to let it go, you have to start to question with that person, well, why would you keep holding on to this defense? You're a smart, accomplished person. We've seen that these defenses have caused all these problems in your life. You're here for me to help you with those problems in your life, but you also don't want to let it go. And of course, as long as you don't let go of this defense, you're not going to make any progress. And why would you come to therapy to make progress only to slow yourself down? Why would you do that to yourself? Right? And we often see, especially with folks that are more highly resistant, that those defenses play out in their relationship with us. So they are pushing us away and keeping big walls with us so that we can't get to know them internally and emotionally to help them with their emotional problems. So typically, often with these more highly resistant patients, we're also bringing our relationship into it and showing them like, look, we see how you detach yourself from me in here. We see that you put a big wall in here with me. And of course, you have free will, like you can do that and I can't stop you and I can't make you not do that, nor would I want to. But why would you come to therapy to get my help only to continue to push me away? Right? And you just keep kind of doing those types of interventions where basically you're telling the truth. And in a way, it's kind of like tough love. like, yeah, you can keep doing this, and, we can keep going on and doing therapy in this way for years and you spinning wheels and not making any progress. But what a waste of time and money. And why would you do that? And you just tell the truth in that way. And the more you do that, ideally, you go from the person trying to have a conflict between you and them, right? Like, I'm not going to open up and you can't make me, to push it back into them. Like, this is not a conflict between you and me. This is a conflict with you and you. You can decide here and now whether or not you want to let this stuff go or not. If you do or not, that's up to you. It's like, it's no skin off my back. But if you want to, I'm here for you and I'll help you. And then, we can make some progress. But as long as you keep these defenses up, we're not going to be able to get anywhere. Now, that can sound really confrontational, but again, it's really only for folks that can tolerate that level of hearing that truth, kind of fed back to them. And so, like, Dav and Lou called it the iron fist in the velvet glove, that it is a tough approach, but it is done out of care and concern for the person, because especially with folks where we see that these defenses have really wreaked havoc on their life. They might be in middle age and, it's trashed all their relationships, the way that they relate to people, and it's caused so many problems. And so it's like sink or swim at this point. Like, let's get to the bottom of this and resolve it now and not waste another 5, 10, 20 years doing this.
What happens then in terms of the restorative process if we're using a certain defense to protect this vulnerability and you're saying, hey, let's get rid of the defense. You don't need it anymore. But of course, the defense is covering up something of a vulnerability or something I haven't seen or implicit part of my history that is going to be opened up with my defense coming down. What would the next step as I open up and get a little bit more space between myself and my defense?
Yeah.
And I start to imagine that I start to experience my body and the fragility of it. But now I don't have that defense.
That's when the vulnerability breaks through. And then it's often very, it can be very dramatic.
Imagine, yeah.
People will start to really, that's when the grief often breaks through. Like, usually that first sort of breakthrough to feeling, as Margaret said, is the breakthrough to grief about how these defenses have hurt themselves and hurt others. And then often that leads to like guilt about that, like how I've hurt others with these defenses. Ideally, that then also leads to some self-compassion. So then you have all of these genuine, deeper feelings that can come through once they're not relying on those defenses. And that is the vulnerability. Is there now, they've taken the leap of faith and they've taken the risk of showing you as the therapist all of these painful feelings and allowing themselves to be vulnerable with you as they're showing you these painful feelings. And then that paves the way for them to really on a deeper and more meaningful level start to talk about, well, what the heck happened to me in my life early on? Because remember, this is a psychodynamic therapy, so we're going to get back to childhood, that made me use these defenses. And then that leads you to start to talk about like some of the traumatic experiences in childhood. And, but they're now opened up to be able to do that. Whereas before they were like, you're not getting in, we're not talking about that stuff. But that, just in having those breakthrough moments, it opens the doorway to be able to do that work.
Can you contrast this too with, because so many therapies, like that's where we want to get to.
Right.
And with EMDR, because I know so many people, right, are trained in EMDR and somatic therapy, maybe not DBT, just because that isn't necessarily the same trajectory. But a quick contrast between those EMDR and somatics.
I want to hear from Margaret, but one thing I'll say, just because it's kind of on this track, is like, I think I'm not an expert in any of those therapies like EMDR or somatic experiencing, but I think that it assumes a willingness of the person to talk about the trauma. And what this model kind of shows us is like, okay, well, maybe some people can get right into talking about the trauma, but many people can't because of these defenses. And this gives you some tools to help them relinquish some of those defenses so that then you can start to talk about some of that trauma and work with it in
Interesting.
the way that you want to work with it. Right.
Yeah.
Sorry, go ahead, Margaret.
Yeah. And I'm, you know, I am trained in a lot of those. I'm trained in EMDR. I'm trained in somatic experiencing. I'm a training junkie. I'm trained in ART and brain spotting and all the, you know, the bottom up therapies. And they don't work with defenses, and they're great for a lot of things. They're great for you know, managing symptoms or alleviating symptoms. What they don't accomplish is character change. And so for individuals for whom the defenses and whether that's someone with a characterological, you know, with a personality disorder or, you know, something like that, or something much more mild also. I think that might be the part of the paper sound anyway. With some of the character change, you know, when the defenses are really getting in the way of relationship, EMDR doesn't change that. Somatic experiencing is not, you know, they're powerful and they're great and they have their place and they can provide some symptom relief, and they can definitely make changes in your pathways and, you know, someone's experience of memory of trauma, but they don't address the structural defenses. And what I kept running into, and this is one of the reasons I don't use EMDR much anymore at all, is I kept running into these people who the structural defenses were getting in the way of us getting to the bottom of it. And I didn't know that. You know, I wasn't trained in anything that would even have led me to understand what the barriers were for people getting healing through these other models. Now, there are a lot of experiential dynamic therapists who incorporate EMDR and brain spotting and other techniques into their experiential dynamic therapy, whether it's ISTDP or Diana Fosha's work with AEDP, Accelerated Experiential Dynamic Psychotherapy. I have to pause a minute if I'm not just throwing out the letters and remember what they actually stand for. But that's what my experience has been. And I've been on both the giving and receiving end of all of those. And they all were really helpful and had their place. And I have not experienced anything either as, you know, on the giving end or on the receiving end, like ISTDP.
You know, you're saying something that really is giving me a little light bulb for sure, because, you know, I was just having a conversation with somebody about psychedelic therapies. And one of the things they were talking about something very similar about how powerful and that the transformative, you know, bottom up experience can be, but that there's no real theory of mind about what's happening and, you know, a way of putting it together with the full personality and with the full, you know, psychological structure. You just have the experience, right? And sort of the need for, you know, filling that out. And I really, really, really love what you're saying about building out the structure, the defense, that you can have, and you can have a really good technique on any of these things, and you get the technique, or you can have the insight with the, analysis and things like that, and have that part. But it sounds like this is something that brings those things together.
Yes.
And I love the accelerated part, of course. That's always wonderful. So I'm actually really interested. If folks are interested in getting trained or learning more, can you say more about what you all have going on coming up?
Yeah, so we there's many ways to get trained in the various models, and one really exciting upcoming way to get acclimated and learn more about the way that people practice this is to come to our conference that we have every 2 years, put on by our large international organization. And so that will be in San Diego this November, November 13th through 15th. And we have lots of presentations from really very experienced folks that have been doing this for like 30 years, doing like full 90-minute presentations, just them showing their work, to newer folks, to sort of what we call like third generation folks, showing how they work, including how they integrate other models into this, including we even have a panel on people who integrating psychedelics in this work, but integrating other models such as IFS and motivational interviewing. And actually, I'm talking about a case of postpartum OCD where I integrated a little bit of behavioral exposure with ISTDP. So we have some integrative stuff. We have some sort of pure either ISTP or APT or whatever it is the folks are showing. And the conference is great because it's like a smorgasbord. You get like so many opportunities to see different people's work. And one of the great things about the EDTs in particular is that we have this tradition going back to Davenlo of video recording the work. And so when you get trained in this model, your teachers and trainers have video recordings of their work that you get to watch. And you have to record your work and show it to your trainers, which is very anxiety provoking. But at the conference, almost all of the panels will be showing actual video recorded sessions, of course, with patient permission that they know that they're going to be shown. And so we only allow licensed mental health professionals in those sessions. So you would get to see that. And then aside from our conference, we have a listserv that folks can join. They don't have to be members of our organization to join it, although we encourage them to also become members, but they can get a taste for what it's like by joining the listserv first. And on the listserv, trainers will post trainings very frequently. And those can be a lot of them are online now since the pandemic. So they're really convenient. And sometimes they're anywhere from a half a day thing or a couple hours to a full like 3-day or 5-day immersion. There's various different ways and different levels of training that you can access.
And we'll share some links as well to some YouTube channels and some other presentations that are available online that people can kind of get a flavor of what this is about. And a number of trainers do, if you kind of want to get a little nibble before you dive into a 3-year training, that there are some really great pre-core trainings and things like that. That's a day long, or a half a day.
Yeah, and will y'all go ahead and give your own socials now and the website and for folks that are listening?
Yeah, so the website for our organization, and I just need to say that because I'm also on the tech and media committee, and it's being updated, so it's a little out. The information is current, but we're prettying it up a little bit. It's a work in progress, yes. It's iedta.net is the organization. And our conference website is iedta2024.com. And if folks happen to be listening to this after November of 2024, it's not too late. They can still come to the conference in Croatia.
Wait, Margaret, that's a surprise.
No. Oh,
Edit
never
that
mind.
out. People don't know the location yet.
Oh, really?
We'll take that out.
Okay, never mind.
Yeah.
There will be you can say there'll be a conference in 2 years, location to be announced.
Yes, somewhere in Europe.
Yes.
To be announced. Never mind.
Yeah.
And what are the other?
And then Deb's socials.
Yeah.
I
for them to
don't really
reach each
have
of you.
socials.
Okay.
Yeah. I have my personal website, but that's pretty much it. Yeah.
Okay. But we'll have all of that,
Yeah.
the information you just gave in the show notes. So if y'all can't keep up with all the acronyms, we understand, but they're there and you'll be able to contact it. You know, as we wrap up, I just have really enjoyed the conversation with you guys. And one of the things it reminds me of is that, you know, we talk about our defenses all the time, that we all have them. You know, I shot just for fun, you know, kind of went into just one particular type of defense that's out there. But just as a reminder that we have defenses that look in so many different ways, whether it's how we hold our anxiety or how we avoid taking using our own voice, you know. So there's so many different ways. And what I like about the model that you're talking about is just a caring way to be able to help us all kind of get a little distance from our defenses, to have compassion about them, to see them, to understand them, and then to take on what they're serving for us and how we can go about changing them, whether that's doing some EMDR, somatic work, all these other elements. It's just like, let's understand our defenses. And I think that's a really helpful model to go by. You've given us a lot to think about. All right. Well, thank you guys so much for joining us. And,
You're welcome. Thank you for having us.
Thanks. Yeah. Thanks for having us.
And for those of you out there, if you find this information helpful, send it along that somebody that might find this useful. It always is helpful for you guys to jump in and rate and review us. Check out our show notes for all the information you can find out there.
That's right. Find us on therapistuncensored.com. And hold on. Find us on therapistuncensored.com. You can find the show notes there. It will be loaded with articles where you can deep dive. And Therapists Uncensored is a sponsor of this conference. So we are definitely endorsers and supporters of it, and very excited to be sponsoring for you guys. And we would really love it if you find this information helpful, if you would get on wherever you're hearing your podcast and give us a rating and review so other people can find this incredible archive of free resources for therapists and for the general public.
All right, you guys, thanks for joining us, and we'll see you around the bend.